Welcome to today's Zoom news briefing. I'm Sandy Close, Director of Ethnic Media Services. Our topic today is COVID is here to stay. Believe it. COVID-19 cases are rising once again, fueled by the emergence of yet another new variant, EG5. Hospitalization rates jumped by 12.5% nationwide in July, according to data from the Centers for Disease Control and Prevention. This uptick comes even as the public health emergency has ended, taking with it free testing and free vaccines. COVID fatigue has set in. People no longer wear masks in public. And a study has determined that the majority of Americans will forgo new boosters, which will be available this fall. Today, we present a panel discussion with 4 eminent speakers who will examine the rise in cases, the new variant, the new boosters, strategies our panelists are taking to prevent infections, as well as the phenomenon of Pax Loves Rebound. Today, we have reserved close to half the session for questions from reporters. So please enter your questions in the chat, and we will get to as many of them as we can. We ask speakers to speak slowly for our interpreters in Spanish, Mandarin, and Korean. We will be sending a video of today's briefing with bios and contact information for each speaker to all participants later today. Let's welcome our speakers for today's discussion. Dr. Peter Chin Hong, Associate Dean for Regional Campuses, University of California, San Francisco, and Medical Educator specializing in treating infectious diseases. Dr. Benjamin Neuman, Professor of Biology, Chief Virologist, Global Health Research Complex, Texas A&M University, and Dr. William Schaffner, Professor of Preventive Medicine and Infectious Diseases at Vanderbilt University School of Medicine. Now I'm pleased to turn the microphone over to our EMS health editor, Sunita Sarabji, your moderator for today. Go for it, Sunita.
Sandy, thank you so much, and welcome to all our reporters and our panelists today. Dr. Neuman will start out with a question from you. Oh, I'm sorry, I should have explained that today's briefing is a roundtable discussion. I will ask questions for the first half hour, as Sandy said, and then we will turn it over to our reporters for your questions. This is news your viewers and readers can definitely use, so please fire away with your questions. So Dr. Neuman, we begin with you, and I have a 4-part question for you. Could you tell us about the origins of the new EG5 variant? How do its characteristics differ from previous variants and subvariants? Is it more infectious, and are there secondary symptoms such as the pink eye that we saw with the Arcturus variant?
Yeah, sure.
A lot to go.
Yeah, we can take a couple of those. So EG5 is one of the variants that's spreading the fastest right now. And EG5 is a child of a thing called XBB 1.9. That's a child of XBB 1.5, and XBB 1.5 is the offspring of 2 different strains, BA210 and BA2.75. These are just a lot of numbers and letters. Basically, it's another version of Omicron, and everything that is circulating in the world right now has about 100 to 110 differences from the original version. Now, back at the beginning of COVID, we looked at this virus and we looked at the rate it would change. And it looked like it should be about 30 mutations per year. And so if you do the math, we are actually right on schedule. And so this is the challenge. This variant is spreading because it has a lot of changes at the receptor binding site. That is the target of most of the vaccines and of some of the most useful parts of the immune system. And when the target changes, you have to change your aim. It has been over a year since we probably should have had an updated version of the vaccine. It's coming slowly. And as you mentioned, uptake has not been great. Total uptake in the US for the bivalent vaccine is only 17%, 17,
Wow.
which I found very surprising. Yeah, someone from Moderna was telling me that last week. So yeah, there's a challenge, but not an insurmountable one. As for the symptoms, the Arcturus variant was reported to cause more pink eye, but that was based on one study, and it was based on 9 children in one part of India. And as a physician, I think the physicians had a job to report this because it might turn out to be something interesting. That variant went on to be one of the most common around the world, and we did not see a big rise in pink eye in other places. So it is most likely that there were other factors involved in that particular case, maybe even people that are genetically similar to each other. And so for now, there don't seem to be any very distinct symptom profiles for this or any of the other variants. You get it, and you get a few symptoms from the grab bag that is COVID-19, and it's somewhat unpredictable. The only predictable thing is that the more recent your immunity, the more recent your vaccination, the less likely you are to have serious symptoms, and that actually continues.
So just a quick follow-up question. With the vaccines, you had mentioned that we are lagging behind, and we've got this new variant. Are the vaccines that are going to be rolling out this fall aware of this variant, and are they going to be effective against this variant?
So there's a 3-step process now. The WHO recommends, and then the FDA looks at the data, and then the CDC will actually act on it, if I have those right, I think. Right now, the WHO have recommended, they did that back in a couple months ago, I think it was in June. And we are waiting for a meeting to be scheduled at the FDA. So the data exist, the companies have them, and it's a matter of showing them to people and getting comment. But the new formulation is supposed to be a monovalent against XBB. That's the one that seems to be most popular. And from the studies that we have now, it looks like new variants like EG5 and FA and all of these are fairly close. They're close enough that a vaccine against XBB seems to work against all of them pretty well. So I think it's a good move, and I wish they'd hurry up. Supposedly it will be about 2 months after the approval for the rollout nationwide.
And final question for you, are there variants of concern, subvariants of concern that you are watching?
It is an XBB world out there right now, and everything on the radar is one of the offspring of XBB. There aren't any that are really standing out as unique or different. It's just an ever-widening family tree.
Thank you. We move on to Dr. Chin Hong. Dr. Chin Hong, welcome. And I have a 4-part question for you as well. Hospitalization rates remain relatively stable despite the summer surge of infections. Could you please explain this phenomenon? And do you expect that hospitalization rates are going to rise at some point? What are you and your colleagues observing in hospitalized COVID patients? Are symptoms and recovery rates dramatically different from previous infections? And do you expect the surge to continue through this fall?
These are all great questions, Sunita. So there has been a slight uptick in hospitalizations, not a tsunami, not even a surge, as we call it, because surge is associated with so many bad memories.
Right.
But I think the way I think about it is a swell. It's kind of like a gentle wave coming. It doesn't overwhelm you. You don't get submerged into it, but you kind of ride it until it goes to the shore. So if you look at California, for example, 1 year ago exactly to the state, we had about 4,700 people hospitalized at one point. And at the beginning of July, it was about 750. So a lot of, that was the lowest point we've had. And California was kind of a mirror of the rest of the country. And right now we have about 890 people hospitalized. So that increase from 750 to 890, is a slight uptick.
Right.
But in perspective, it's nothing compared to even 1 year ago when it was 4,700. So a few things are, first of all, why are cases going up slightly? It's because of probably 3 or 4 things. People are getting together more, including internationally. There's also simultaneously an uptick in cases in Ireland, in the UK, in France, in Brazil and South America, in China and Japan, and in Australia and New Zealand. So no matter where you go, you come back. And then there are big concerts like Taylor Swift, bringing a lot of people together. The second reason, of course, is that, unprecedented heat waves have driven a lot of people indoors. So it's kind of like a winter almost, even though it's the summer. The third reason is more immunologic, which is people's immunity is kind of waning from the last time a lot of people got infected, which was last winter, 6 months or so. And then the fourth is probably related to what Dr. Neuman talked about, although it's speculative at this point, the role of how EG5 might relate to this uptick. But you're right, Sunita, at the end of the day, we're seeing so many people get COVID in the community. The hospitalizations haven't really been, such a large uptick as you would expect, like in the early days. And I think part of it is because we've all been so exposed to COVID already. It's almost like it's coming on inhospitable soil as a community, more than 95% with combined either having had an exposure or having had a vaccine at some point. So, that probably minimizes or mitigates the risk of serious disease. The second reason is that I think we've become better at knowing what to do once somebody has COVID. In the old days, we were reserving remdesivir for seriously ill patients. And now we know, and, I think ask anybody, before COVID, and you'd say the earlier you treat infections, the better it is. Look at HIV, look at many other exemplars. But in the beginning of COVID, we were reserving treatment for those who were more seriously ill until we got the data. So I think there's much more uptick, even though we can do a lot better with early treatment, not only in the community with Pax Loves, but in the hospital setting. As soon as somebody hits the door with COVID, we're giving them, antiviral treatment. The third reason is that even in people hospitalized, we're not seeing as much serious disease, most serious going to the ICU. At UCSF, for example, today we have about 25 people in the hospital, 3 people in the ICU, and only 1 person is ventilated. In the old days, it would be like a much higher proportion of people seriously ill of the people with COVID. So what it also suggests is that people are not just only coming in, fewer people, proportionally speaking, coming in with COVID. Number 2 is that of those who are coming in, they're not that as sick as they used to be. Some people don't even have COVID symptoms. They're being incidentally checked with COVID. So the revolving door of people coming in and out is faster than in the old days. It would be stacked up. So I'd admit 5 patients they had COVID and they would stay in the hospital for a long time. Then I'd admit 5 more and they'll add to the 5. So it will be exponentially going up. Whereas the 5 people admitted today, in 2 days, they may be leaving the hospital as opposed to staying for 5 or 7 days. So it's very complex, the situation of what we're seeing. In the big picture, not as many people are getting ill as in the old days. We have a lot more tools. We're getting better tools. Not as many people are seriously ill, and people are having shorter stays, and not everybody has COVID symptoms once they're hospitalized. But we are still seeing some sick people, and we're still seeing about 300 or 400 deaths per week in the United States, not 2,000 a day like we used to. But the tragedy is that most of these deaths are avoidable because of the tools that we have. It's just recognition that the sniffle or that nasal congestion you have with that tickle in the throat is COVID, because time is money. And the earlier you have COVID, the earlier you can do something about it instead of sort of lingering. And, that is kind of my worry to the future. In terms of forecasting, I think the swell will hopefully roll over. Probably will be a little while with schools reopening, but then we'll have a larger winter rise. So it may be that COVID, we are thinking, well, is it going to be like influenza and we'll see it one time a year? But now this is the 4th consecutive summer. And as the summer gets hotter and hotter and people are driven indoors, it's almost acting like a winter. So we may end up with a situation of a smaller rise in the summer and a bigger one in the winter, with a sort of a space in between.
Interesting. Thank you so much. You had mentioned extreme heat driving people indoors. A lot of our reporters are working on a project in tandem focusing on extreme heat. And I wonder if you could answer this question. Does extreme heat make us more vulnerable to COVID infections?
Well, that's a great question. In the old days, we used to say, when people did studies in the beginning of COVID, they would find that it was much, it's easier, and Dr. Schaffner can probably comment a lot from influenza and all this stuff, with less humidity to sort of like, that humidity might influence the persistence of virus in the atmosphere. The second reason is that heat and UV light, at least in the laboratory studies, was seen to be good for not having a lot of virus around. But what happens with heat is, of course, it's more of a human aspect than the heat itself and UV light that brings noses and mouths together. And also when you're hot, you're like rubbing in your face, you're like washing, touching your nose and mouth. There's even an interesting study recently showing that people who picked their nose more had more COVID compared to people who didn't. So again, it's testing to the fact of, you rubbing your face with that soaked in fluid. The other thing about heat, of course, in air conditioning is that it depends on the setting you have, if you're recirculating air or bringing air in from the outside. So, lots of other factors, I think, not necessarily the idea of heat on the body, although heat on the body has lots of other effects as well, on, risk for heat stroke, cardiovascular, and all of those other aspects. But I think it's a complicated story with COVID, given the human factor plus the environmental factors.
Thank you, Dr. Chin Hung. Dr. Schaffner, questions for you. Paxlovid and remdesivir are currently the only therapeutics we have in our arsenal to battle COVID, but both are problematic. And I'm wondering if you could explain some of the challenges with each therapeutic. Are there additional therapeutics in the pipeline? And you can generalize on this and when we might see them rolling out. And how do we ensure that all people get the therapeutics they need, even as we end the public health emergency?
Well, Sunita, you ask very good questions. let me try to put them into perspective and say that one of the best global responses to COVID, and I'm including people around the world, has been in the research community. On the bench laboratory investigators, I mean, this was a virus that we had not encountered before when it first appeared. They had to understand how this virus existed, how it multiplied. They quickly determined its genetic component. And in very short order, imagine this, we had, first of all, diagnostic tests that were so rigorous, they could be done at home. Amazing. Number two, of course, we all know the vaccine story, which were, and there have been many vaccines developed around the world. Number three, to your very point, we developed therapeutic agents for COVID infections, studied some drugs and put them aside and discovered they did not work. That's as important as discovering the new drugs. Then clinically, and Dr. Chin Hong certainly knows this, we learned a lot about how this virus affects the human body, and we became much better in treating. All of this information transmitted globally. And lastly, the research related to public health, defining the epidemiologic characteristics of this virus, how it spread, its new subtypes, as Dr. Neuman has been telling us, and what their characteristics are. Now, could we use more research? Absolutely. And that has to do, just as you said, with even better therapies. Paxlovid, we know that if you administer it, particularly to people at high risk, very shortly after they are infected, we can reduce their risk of developing severe disease. But Paxlovid has limitations, as any therapy does. There are drug-drug interactions. So if you're taking certain medications, you have to be careful about taking Paxlovid, or you may not be able to get it. If you have kidney failure, we have to be careful about the Paxlovid dosing, for example, or remdesivir. Again, as Dr. Chin Hong has been saying, we now use it very quickly once the patient is admitted to the hospital. But wouldn't it be better if we had more therapeutic agents aimed at keeping people out of the hospital? Studies still continue on other therapeutic agents, but I cannot tell you when they will become available. I think we'll just have to see. But the research community continues, I think, to make some of the very best contributions to the control of COVID around the world. Now, here in the United States, how we can make sure that the new vaccine, which we hope will be available sometime in September, maybe late September, as well as therapeutic agents are available to everyone who needs them, will now continue to be a challenge, because we are now using the conventional medical care system in this country. And you know, we have disparities in access to medical care in this country. We are particularly concerned about minority communities, minority by language, by race, ethnicity, rural location, and all of those things will continue to be a challenge as we manage COVID going into the future. And as you said, and as Sandy said, we are going to be living with COVID for the foreseeable future. It's part of our ecology.
Thank you. Just a follow-up question. We have seen the phenomenon of Paxlovid rebound, and this is just empirical. I have no data to support this. It seems as though everyone that I know that's taken Paxlovid has also experienced a rebound. Can you explain this phenomenon? And I asked you this question informally in an email. When a person is experiencing rebound, are they infectious once again?
Well, the data are incomplete. First of all, I'm glad to say, despite your experience with friends, rebound is not a universal phenomenon.
Okay.
The last data I seem to remember is that about a third of patients get some form of rebound. Often they are less ill. That's very good. You know, the Paxlovid has suppressed the replication of the virus, probably has not done so completely. And there is then some inflammation that occurs afterwards when the Paxlovid is withdrawn. The data that I have seen, and I invite Dr. Neuman and Dr. Chin Hong to come into this discussion, as I seem to remember it, your infectiousness is substantially less during the rebound period, but I welcome their contributions.
Do either of you want to weigh in, Dr. Chin Hong or Dr. Neuman?
Yeah, I can start, Sunita. I would say that one other big point is that in many studies, some studies have shown even a lower rate of rebound. The main point is that the people who are not taking Paxlovid have very similar rates of rebound when you look and you follow people over time. It's just that we're, I think, as humans, sensitized to looking for more symptoms that develop once you stop taking Paxlovid once you stop taking Paxlovid. So I think that might be a phenomenon. I think it is real, like Dr. Schaffner points out, but there's also a very similar proportion of people who are not taking Paxlovid where there seems to be a phenomenon. Clinically, I would say that for people in the hospital, we've certainly seen a significant number of people who get better and then they get more symptoms, but the symptoms when they get it again is always much more subtle and not as severe as the first time around. So it suggests that, the viral load is lower, although I haven't seen great studies around that. But to be conservative, CDC says that if you get rebound, you treat it like you're getting COVID for the first time from an infection control perspective. Dr. Neuman, do you have anything else to add to that?
Only that there hasn't been an authoritative study on when a person's infectious or not, and there's enough variation that I would always say if there's virus inside, there's a chance it's going to come out, and I don't like taking chances with COVID. Yeah.
Okay. We are going to move to questions from reporters, but before we do, I would like to ask each of you, how are you keeping yourselves safe amid a summer resurge? Are you still wearing masks? What else are you doing? Dr. Neuman, do you want to start out since you're on our screen?
I'm living as a recluse. Thank you. Yeah. When the teaching term starts up in about 2 weeks, I am going to wear a mask through the first month, and then we'll see where cases are, and then maybe I'll take it off, but we will see.
Okay. Dr. Schaffner, your mask.
Yes, I continue to wear a mask. You'll see gray hair. By the way, that's just a little biopsy site from a dermatologist this morning. Don't let it bother you. But yes, because I am over 65 years of age, my wife and I both continue to wear a mask when we go out into public circumstances, and we both continue to be really quite cautious, particularly so since we've had this increase, small but nonetheless notable, particularly in the southeastern part of the country where I am.
Thank you. And Dr. Chin Hong.
Well, I'm certainly carrying on my mask everywhere I go now. I'm not using it in the majority of places, but I think during touch points, so that is public transit, in the airport going in and off the plane before the ventilation goes on. And yesterday I went to see Aladdin in San Francisco. It was
Nice.
a traveling show, and I took my mask, and in the beginning indoors, a lot of crowds, so I wore it then and exiting too. I mean, as somebody who's up to date on vaccines, I'm not worried about getting seriously ill, but I don't want to get COVID for disrupting a work meeting that I have to go to or visiting my mom next week. And I also don't want to give it to her. So particularly in that period before I'm going to see her, I'm going to be even more careful. And there's a non-zero risk of getting chronic symptoms. It's been getting lower over time with vaccination, Pax Loves, and with the newer variants compared to the old, as shown by census data and questionnaires and people from the census, but it is still non-zero. So again, I'm not putting myself out to get it, but I'm just trying to, adjust to the new normal and go as time goes on.
Thank you so much. Now we're going to move to questions from reporters, and Henrietta Burrows, you are on first as always. Please ask your question.
Thanks so much, Sunita. Dr. Neuman answered it in the chat about people who get vaccinated and have symptoms of long COVID. So I don't know if the other doctors might have something to say about that. And
yeah,
also,
please ask your question again so that we have it for the entire group.
Okay, I had said that some people who get the vaccines are having symptoms of long COVID. How widespread is this? What is the prospect of it increasing? And what can be done to reduce this outcome? Also, the other question is, I thought heat and UV rays, sunlight, are supposed to kill germs and viruses.
Who would like to take that on?
I can start. First of all, with and thanks for your question. The UV light and higher humidity is conducive to having lower reproductive number for the virus. So, but what I'm saying is the human factors, because of the heat, bring people together indoors, and that's really the potential contribution to increase. One of the potential contributions in the winter, you'd see even, the triple effect of less UV light, less humidity, and more people going indoors. That's why probably you see a larger number of cases in general, including not just COVID, but other respiratory viruses in the winter compared to the summer. But the summer is not, insubstantial either. And then my take on the sort of chronic symptoms after the vaccine, not substantiated by data yet. And there've been a few anecdotes, but nothing published or in the peer-reviewed literature that I know of. I welcome Dr. Schaffner and Dr. Neuman to give their perspective as well.
Yeah, Dr. Neuman, you answered Henrietta's question in the chat, but we also have the Spanish, Mandarin, and Korean interpreters, and so we need them to get the information as well. So please.
I can try. Dr. Chin Hong gave a very nice summary, I thought. So the last paper that I read said that about 10% of people have symptoms that persist for longer than a month, which is kind of a working definition of long COVID, although your definition may vary and there are many out there. Most people who had long-term symptoms also had detectable virus in their body. So while the symptoms may be mostly driven by the immune response, the root cause may still be the virus. So there is a chance that with combination antiviral therapy, for example, like we use against HIV, it may be possible to actually help. There are ongoing clinical trials looking at combinations of therapies and looking specifically at the effects of these therapies on long COVID, but they're not done yet, so we don't have a definitive answer. On the UV thing, all I would say is that UV also damages your cells And I think the effect on people is perhaps almost as great as the effect on the virus. So if you're not succumbing to the UV rays, you shouldn't expect that COVID would necessarily. Oh, and the last thing, is that I know that the FDA and CDC would tell you that you're either up to date or not up to date with your vaccines. But until the vaccines are updated, no one is up to date because they haven't rolled out an updated version that protects for longer than 2 months, of sterilizing immunity. So until they do, we're all kind of hanging and waiting.
You've mentioned that when you've been with us previously, and I definitely take that to heart. Dr. Schaffner, I would like you to answer a question from Araceli Martinez of La Opinion. Araceli, please ask your question.
Hello, can you hear me, Sunita?
Yes, we can.
Yes.
Welcome.
Thank you. I believe that there is some kind of confusion right now about what is the best way to protect us, and also about the vaccine, when we should get the next vaccine, especially for those that got the vaccine last winter. And I have seen new cases in Los Angeles of people getting COVID. So based on all of these that you just talked, what would be your best recommendation in order to protect us?
Thank you. Dr. Schaffner, do you want to take that on first? We may have lost Dr. Schaffner. Dr. Chin Hong.
Yes, I hope Dr. Schaffner comes back on. Oh, can
Here
you
we
tell?
go.
Oh, yeah, great.
Oh, there you are. Okay, would you please answer Araceli's question? Did you get it?
I got it, but I need to put a little postscript to our previous question. Let us make it clear, the vaccine is not associated with long COVID. There are some people who have received the vaccine who nonetheless can get COVID. We all know that that can happen. The vaccines seem to have some effect in reducing the likelihood of long COVID, but yes, you can get COVID, and as a consequence, long COVID, even though you have been vaccinated. But the vaccines really reduce the risk of long COVID. And then one other thing, the National Institutes of Health have now just initiated a very large program going forward of research, trying to look at the causes of long COVID and also better treatments for people who have these long COVID symptoms. So we look forward to those results, but they will not be ready in the immediate future. Now, to the new question. The next vaccine that will be available will be a monovalent vaccine. The manufacturers are working on this now. It should be available in September, perhaps late September. We will wait for recommendations who should receive that vaccine. For sure, people who are older, have underlying illnesses, who are immune compromised, and women who are pregnant. For sure, they will be asked to receive the vaccine. There will be discussion about younger, healthier people and children. So stay tuned. What can we do right at the moment? There is a bivalent vaccine available today. And if you have not been vaccinated for a considerable time, cases are increasing. I would say go ahead and get that vaccine now. And yes, you will then get another vaccine in September, October, or November during that time. We have also mentioned people at high risk. Wear that mask. If you are going to visit, as Dr. Chin Hong is going to do, his mother, who must be a little bit older, one of the things you can do is test before you visit to make sure that you are negative, or it certainly reduces the risk that you are positive. So there are several things that we can do right now to be careful. And if you are in a high-risk group, older, underlying illnesses, immune compromised, I don't know that you ought to go to a Taylor Swift concert.
Absolutely. I don't know that you need to go to one anyway, but that's editorializing. Daniela Masterson has her hand up. So Daniela, let's ask your question.
Hi, good morning. This is informative, and I feel like I'm falling in the cracks, but I'll try to fill in. I'm working on behalf of the Precinct Reporter. It's the largest African-American paper in IE. So our concerns obviously are for our readers who are largely African-American and older. And as I recall, there was so much happening, but as I recall, the African-Americans were at a high risk, minorities were at a high risk. And so how do I let my readers know to be aware? Are they at risk still? Is it advisable that they go and get this vaccinated right away? I'm trying to decipher what my message is going to be for our readers.
Fair question. Who would like to take that on?
I can start. Thanks for your question, Daniela. I think, as you pointed out, throughout the pandemic, we've seen a lot of disparities, including and particularly amongst the African American communities, both in terms of who is dying first of all, and who is being hospitalized. But then we began to address some of the root causes, which were related to access to testing, and related to probably a lot of structural racism that was highlighted in terms of underlying issues in many vulnerable communities. I think it was interesting that, and of course, politics played a role, but even after the new administration, those disparities still persisted. I think one silver lining was that vaccinations increased uptake in all communities, probably given the advocacy of a lot of grassroots organizations and community-based organizations. So where does that leave us now? I think there's been probably less attention paid to how COVID is affecting different communities, but I do worry particularly that testing is linked to access to early therapy. And because testing has a premium and price associated, that will leave a lot of people behind, because who's going to go and pay $25 for a test in Walgreens if you have some sniffles and it might be allergies, and then it might be too late. So what is still free? Well, what is still free and available to everybody is, like Dr. Schaffner passionately spoke about, is vaccines. Even before the new one comes out, there's the one now, and we know that only 17% of the general population has gotten it. So I think that probably will be one easy way to protect the population, particularly those in the community older than 65 and those are immune compromised, because at least I know in my heart that even if they get the sniffles, even if it's COVID and they couldn't get a test right now as the cases are increasing, that it will be at least somewhat protected against serious disease. So that's kind of and long COVID
just
too.
I'm so sorry, just to clarify, are vaccines still free even with the end of the public health emergency?
Yes, vaccines are still free. There's a bridge program that's going to probably come into effect nationally that will allow people without demonstrating ability to pay to get them, at least till the end of the year. In California, written into law until November, and probably extended with a national bridge program. Anybody can get vaccines for free. And hopefully that will be extended. And then if you have insurance or medical, people are obligated to give you the vaccine for free without copay because of the Affordable Care Act. So the main thing to also arm the population and the community with is knowledge that these things are free and nobody should be charging you or threatening you with a copay, because they're all supposed to be free. And if you don't get the right answer from one drugstore, then go to another drugstore until you speak to the right person.
That is such important information. Thank you so much. The next question is from Vijay Sundaram. And Vijay, please go ahead and ask your question.
So I was wondering why no research is being done on whether nitric oxide could be used as a therapy to treat COVID. When it was done, research has been done at Mass General on SARS, and it's been found to be very effective. And I think SARS is a very close cousin of COVID. Why is no research being done on it to see if it's effective?
Excellent question. Who would like to take that on first? Dr. Neuman?
I was just going to pull up a couple papers and see if I can come up with a sensible answer. Dr. Schaffner may know, or Dr. Chin Hong may help.
I was hoping Dr. Neuman would know. I don't know this literature. It sounds provocative. It also sounds as though even if it had some therapeutic value, it would not be easy to administer to large numbers of people. But nonetheless, it's a provocative notion, and I don't know the early laboratory data on that subject.
Anyone
A little
else?
refreshing, I can try. So it's a short range molecule. This is something that's going to break down into free radicals and destroy the thing that it's next to. It's released by a number of different cells, among them some kinds of white blood cells. It would be hard to put it into the entire body and get it to go to the right place, I think, yeah. But any therapy that seems to have promise should probably be investigated in some way. And yeah, I see some papers that are talking about it as something with potential. But this would be immunomodulatory. So this would be affecting the performance of cells in the immune system rather than directly targeting the virus, because it's just a molecule and it doesn't know where it is or what it's trying to do. So possibly there may be something, but we've tried a lot of things and that haven't worked so far. But I guess, yeah, you dust yourself off, get up and try again.
Jan Newcomb has the next question. Jan, please. I'm sorry, June Newcomb. Sorry about that. Please ask your question.
Good morning. What to you is pandemic fatigue? Is this really in existence now? Because many are using this reason for being relaxed again.
Yes.
Thank you.
That's an excellent question. And I think there are several questions related to that, of COVID fatigue, not wearing masks, not taking the new boosters, etc. Who would like to address Mr. Newcomb's question?
Well, I guess I might start, and my colleagues can add to it. If I understood the question, yes, we are beyond the pandemic phase, namely that part of the infection that affected our society such that the healthcare system was extraordinarily stressed, as Dr. Chin Hong said earlier, with many, many people in hospitals, seriously ill and dying. We're now in the endemic phase, which means that the virus is among us, even though it's affecting us at a lower level. But this continues to be a global problem. We must remember that, and it will continue to be a notable cause of illness and hospitalizations, just as influenza is. So we cannot dismiss it. I'm sorry of COVID fatigue, but the virus is not fatigued.
Right.
It is still with us and able to transmit. Sandy can speak to that. and make people miserable for a number of days and can make highly vulnerable people still very sick and admit them to the hospital. So we've put the pandemic word aside, but that does not mean that we have put the virus aside. The virus is still with us.
Excellent. Peter White has a question that I think would be appropriate for Dr. Neuman. Peter, please ask your question.
Okay, hi, yeah, let's see, where is it? Well, it was just, see, I can't find it in this chat. These latest variants, they're, off the Omicron branch of the tree. And my question is, they seem to spread faster, and that's why they're more successful than variants before them. But the infections that they cause are not as serious. We've spoken to that earlier during this briefing and other briefings as well. My question is it this normal behavior for viruses over time?
That's a good question.
Hey, Ben.
So we've only really known that viruses exist for about 100 years. And the first thing we knew was that they were very, very small. And fast forward about 50 years, we knew that they were very small and they had particular shapes that were interesting, neither of which is very useful in answering your question. We get to the 1980s and 90s, and we start to get some genetic information, mostly on DNA viruses, but a few RNA viruses like coronaviruses. And so most of what we know has come in the last 30 or 40 years. And really, we don't have enough basis to be able to say this is what viruses will do over the long term. I think what you're suggesting is what everybody hopes. And certainly I've heard enough people say it that I'm pretty sure everybody wants this virus to kind of curl up and quit on its own. I just never trust viruses enough to put any money on that.
Thank you. Katie Sinclair has the next question, Katie, please ask your question.
Oh, well, can you hear me?
Yes.
Sorry, I think you guys answered it. I was wondering for myself and for my readers, should I just go get another booster before the new thing comes out in the fall? And it sounds like you should do that.
Anyone want to clarify?
Well, I think it's complicated or nuanced. So I think that it's okay to wait for it. It will be a closer match. Like Dr. Neuman was alluding to earlier on, probably the best protection will be right after you get it, so that you may want to time it like the flu shot, although it's like timing the stock market with when you might see the surge to get the biggest bang for your buck. However, if people haven't received their vaccine for quite a while now, like some people haven't received a shot or were infected, like if you're Novid and you haven't received your vaccine, there is enough COVID going around where you may be at risk for getting seriously ill. Like Dr. Schaffner pointed out, it's not going to exclude you from getting the new shot. You might just have to wait a little bit longer, but still in time for the winter surge. So where does that boil down to? If you're older than 65 or immune compromised and you haven't gotten your shot for a while, meaning more than 6 months, most people got it in the fall of 2022. You might go ahead and get it. If you are somebody who also is in that category, but younger and is relatively healthy. If you are like somebody, I'll give you a question. Somebody who was breastfeeding, has a newborn, and is worried that they're going to get COVID with this surge, is thinking about getting it because then she may develop protective antibodies. She hadn't had COVID for a long time, if at all, hadn't gotten vaccine for a while. So she may get it just because she can protect the baby in the early period from COVID through protective antibodies. So these are just individual situations that might arise.
Great. There are so many more questions. I see 2 hands raised. We will take the final question from Manuel de Paz, and then I'm going to ask each of you for your 1-minute sound bites and close this discussion out. Manuel.
Thank you. Good morning. First of all, I have some comments, and I see in the community that a lot of people think that the COVID is gone. I have heard from people, that I talk to, COVID is gone, we don't need to use mask. That's one thing. The other thing is that mostly people is tired of wearing mask, and we know that wearing mask is the best weapon and protection that we have against this virus. And I am working on, informing and educating the community. And my experience out there is that a lot of people, even the people who are working in campaign with COVID, is not wearing mask, when we go outdoors. And I seen a lot of people, for example, in the train that are not wearing mask. And so we know that, wearing the mask is, protect us, right? So my question is very confusing that where we should wear the mask. For example, if I go outdoors, working on the park, if I'm walking alone, I think I'm safe. But if I see, a group of people coming, passing by me, should I wear the mask or, or I should not? That's
Dr.
one of the
Schaff-
questions. And the next question is—
Sorry, Manuel,
Yes.
we're going to run out of time. So may I have Dr. Schaffner address your question and then—
Yes, but my question quickly is for Dr. Williams, and he was talking about to have therapeutic methods besides vaccines. Are there other therapeutic methods that can be used to fight COVID? That was my main question.
Okay.
Well, very quickly, Manuel, I would emphasize wearing masks indoors when you are surrounded by many, many other people. That's the high risk area. Outdoors, your risk is much, much, much lower. I wouldn't worry about that so much. But indoors, religious services, concerts, even restaurants and things such as that, certainly travel. If you're on trains, airplanes, buses, those are the times when I would wear a mask.
Excellent. So we go to our final bit of this segment where I'm going to ask each of you your 1-minute soundbite. What would you like our reporters to take away from this conversation? Dr. Neuman, let's start with you.
Okay. So the moon is far away, Mars is far away, but we've been to both of those. It seems like the end of COVID is far away right now, but I have to believe that with human ingenuity, we can get there. I think the biggest challenge was and is in people's hearts, convincing them not to fear the new and the newly approved, and to do everything in their power to stop this virus, because it doesn't add anything to life. It only takes it away. Right now, there's not a great surge, and consider that we are doing almost nothing to stop the virus. So I take heart from this, and I do still think we can get there.
Thank you. Dr. Schaffner.
Emphasizing and extending Dr. Neuman's comments, we have to remind ourselves that although the pandemic has receded, the virus is still with us and will be for the foreseeable future. It has the capacity to make people very, very ill. As I like to say, the virus is bad, vaccines are good. Take advantage of the new updated booster vaccine that will be available this fall, starting sometime in September. That will provide the best protection for yourself, make sure your family is protected, contribute to the protection of your own community.
Thank you, Dr. Schaffner. Dr. Chin Hung, final word to you.
Well, I like the way that we're ending on a note of optimism. Again, for me, always the glass is not half empty, it's half full. And who would ever believe that we rally together as a world to have so many tools to solve this crisis? And even though it's going to be around with us, I mean, the 1918 influenza pandemic, there's still vestiges still today. But the point is we have these tools and it's up to us to use it. And, you know, science and taking care of ourselves is not a political issue. So I don't want to bring it back to Taylor Swift, but the reason why Taylor Swift was so incredible was that it drew people from all walks of life. So I think drawing on that, I mean, if we can come together once a year, at least to prepare for the winter and not just think about COVID, but all respiratory viruses. We have a lot of tools against influenza. We have emerging tools for RSV as well. And wearing a mask can have multiple effects, not just for COVID. I mean, who doesn't want to get less sick during the winter? And we have to take care of all populations and make sure everybody has access and ability to get these tools. So that's my final word.
Thank you. Thank you so much to all of our speakers and to all of the excellent questions from reporters. This has been a fantastic briefing. See you next Friday when our briefing focuses on back to school and the issues associated with a very polarized schooling environment. See you next Friday at 11. Take care. Bye-bye.